Hi, my name is Jasmine Lord. I work at Baylor Scott and White Health here in Central Texas. We are a teaching and research facility, so when I first had to address a patient safety concern, I did have some trouble because we do a lot of things well here. But I did find that in our medical ICU, we have room for improvement with early mobility. So today I'm going to address intensive care acquired weakness. First, let's discuss intensive care acquired weakness and what it is. It's the deconditioning due to an intensive care hospitalization. Per Hopkins and colleagues, neuromuscular weakness due to disuse atrophy, decrease in strength, and functional denervation can be triggered due to prolonged immobility in the ICU. Just 1 week of bed rest can result in a profound loss of muscle strength up to 20%. The Agency for Healthcare Research and Quality states that strong evidence of mobilizing critically ill patients is safe and feasible, is cost-effective, decreases duration of mechanical ventilation, and decreases hospitalization and ICU length of stay. So what does this mean to us at Baylor Scott and White Health? Well, per the MICU unit manager, last quarter, from May to August, only 45% of patients were engaged in early mobility. And our facility defines early mobility as mobilization of patients once hemodynamically stable, and that follows a progressive order of bed rest, bed and chair position, dangle, out of bed to chair, and ambulation. In addition, management noted that 38% of patients on mechanical ventilation had orders for physical therapy, so we definitely have room for improvement. The aim of this project is to increase the percentage of patients engaging in early mobility from 45% to 65%. To have a dynamic approach in addressing intensive care acquired weakness, we're going to use IHI's framework for patient safety, which includes organizational culture and learning system. Organizational culture is defined as the product of individual and group values, attitudes, competencies, and behaviors related to safety. Learning system is measure performance and helps teams make improvements. So what are we going to do? Our first intervention is to initiate progressive mobility as soon as hemodynamically feasible. Per Drolet and colleagues, studies show consequences of prolonged bed rest have conducted in those without illness have skeletal muscle changes that have been documented within 72 hours of physical activity. So engaging patients in early mobility as soon as physiologically allows can reduce the impacts of intensive care acquired weakness. This is going to be measured by accurate documentation of mobility per shift. If early mobility was not initiated, we need explanation to determine the inability. Our second intervention is going to be initiating daily disruption of sedatives to accurately assess ability to mobilize to promote the highest level of mobility. Dang states that a patient requires a disruption of pharmacological sedatives to appropriately assess the stability and safety of the patient. Daily disruption of sedation also decreases the risk for delirium and cognitive impairment that can hinder the patient from mobilizing early. This is going to be measured by if a sedation holiday was performed or not, and to assess the ability to mobilize per a 24-hour period. This is going to begin at 0500 and the night shift will perform this. Our third intervention is going to be to identify those at risk for intensive care acquired weakness and encourage physicians to order physical therapy daily. We're going to implement this project using PDSA, Plan, Do, Study, Act. The plan is we're going to educate our MICU nurses, we're going to coordinate with IS to personalize epic charting, and we're going to designate nurses who will assist in data measuring. Next, we're going to do. The nurses will utilize the 3 strategies identified in interventions and document those respective interventions accurately. The designated nurses will perform chart audits and round the units to assess data. Lastly, once the data is collected, we will determine if 65% of the patients are receiving early mobility during intensive care hospitalization. If 65% of the patients are meeting guidelines for early mobility, continuation of the project will occur, and we'll strive for a higher percentage for next quarter. If less than 65% of the patients are meeting guidelines for early mobility, review of the project will occur and adjustments will be made accordingly. Below are my references, and thank you for your time.